Today's lecture is about lupus nephritis. SLE is one of the most common autoimmune diseases which affect the kidneys. So we will start with the lupus nephritis and discuss in detail. Uh, in the previous two lectures, we have talked about the clinically applicable basic concepts of the glomerulonephritis, which include inflammation, consequences of inflammation in the glomerulus, how the inflammation starts in the glomerulus, role of the immune complexes and complement system in the glomerulus, glomerular inflammation, the concepts of proteinuria and concept of the glomerular hematuria, and their clinical implications. We have discussed about those things. Now we will translate all those basic clinical concepts into the different diseases so that they have the name to the they have the name to the faces as well. So we'll start with the lupus nephritis. Remember, lupus can involve any part of the kidney. What the book mainly emphasizes is the lupus glomerulonephritis. But even within the glomerulus, lupus can have many diseases which are not included in the lupus glomerulonephritis, but they are still diseases within the glomerulus. Okay? So I'll come to those things first, but first I will start with the lupus glomerulonephritis and talk about its different manifestations and the stages, and then we'll go ahead and talk about the non-glomerulonephritic glomerular diseases of the lupus. So if you look at the in this picture, basically there are six stages of the glomerulonephritis with reference to the lupus. Stage 1 and stage 2, as the diagram, as this picture shows, stage 1 and stage 2, they are the proliferation, they are inflammation of the mesenterium alone. Only the mesenterium is involved. Basal membrane, capillary endothelium, Bowman's capsule, they are all normal. It's just some immune complex deposition in the mesenterium which causes inflammation and proliferation of the mesenterium. So only mesenterium is involved. Capillaries are normal. Bowman's capsule is normal. Therefore, the disease is usually very mild. Clinically, it may be silent or may just a minimally symptomatic disease. So this mesenterial alone inflammation has stage 1 and stage 2 of the lupus nephritis is only mesenterial inflammation. The difference between stage 1 and stage 2 is that stage 1 is so subtle, so mild that light microscopy doesn't detect any inflammation. Whereas stage 2 is a bit more advanced than stage 1, and inflammation and mesenterial proliferation is detectable by the light microscopy as well. Remember, stage 1 is not normal mesenterium. It has inflammation, it has proliferation, but it's very subtle, which is detectable only by the electron microscopy or by the immunofluorescence staining, but not by the light microscopy. Stage 2 is the disease is a bit more advanced than stage 1, and that is detectable by light microscopy as well. But as the disease is limited only to the mesenterium, so the clinical symptoms are very minimal. Either the patient is completely asymptomatic. That's why these are often not biopsied and they may go unnoticed, or they are detected when the biopsy is done for some other reason. And secondly, even if they're symptomatic, there may be some glomerular hematuria because of the inflammation in the mesenterium, which is next to the capillaries, which may damage some of the capillaries, but just as a spillover effect, or may cause mild fall in the GFR because of compression of the capillaries caused by the mesenterium. Okay, so if you look at these pictures, figure 1 and figure 2, figure 1 is basically stage 1. This blue is mesenterium in these figures, the red is basal membrane, the black is endothelium, and the green is a Bowman's layer. So in figure 1 is basically stage 1 and stage 2, when only the mesenterium is expanded. There's expansion of the mesenterium in figure 1, but the basal membrane and capillary endothelium, they are all normal, and Bowman capsule is also normal. So these are the stage 1 and stage 2. Usually these diseases are very mild and they may not need strong immunosuppressive therapy. Detection of the stage 1 and stage 2 in the clinical biopsy of the lupus patient may need mild to moderate immunosuppression such as oral prednisolone along with azathioprine or mycophenolate. The stage 3 and stage 4, they involve mesangium, plus the disease also extends to the capillary endothelium and the capillary basal membrane. So stage 3 and stage 4, they're a bit more extensive. Remember, three things are involved. One, mesangial involvement as is involved in stage 1 and stage 2, but a bit more advanced. Plus capillary endothelium is also involved, and plus basal membrane is involved as well. So three things are involved in stage 2 and stage 3. So if you look at this figure 2, in this picture, and if you look at the mesangium, it's more proliferated than stage 1. You look at here, and then if you look at the capillary basal membrane, the red one, it's clearly there are two layers of the basal membrane. Okay, this is because of the thickening and splitting of the basal membrane. And if you look into a bit more detail, the mesangial, which is blue, has actually invaded and entered into the basal membrane. Okay, because normally in most of the other glomerulonephritis, when the inflammation starts, it doesn't involve the basal membrane. Okay, but in membranoproliferative variety, it has inflammation and proliferation of the endothelium and mesangium. At the same time, it also involves the basal membrane and causes dispersion of the collagen. And because of the dispersion of the collagen, the membrane becomes thickened and widened, and the mesangial cells, they can actually physically enter into the basal membrane. It causes splitting of the basal membrane. This is called this double layering or multi-layering of the basal membrane is, you can see in this picture, there are two layers of the red basal membrane, and this is called as a tram-track appearance. It can be more than two layers as well. And this is a very diagnostic of membranoproliferative. Proliferative means there's inflammation, and membrano means there's a membrane involvement as well. Normally, the inflammatory glomerulonephritis, they do not cause splitting of the basal membrane unless the membrane itself is also involved by a separate disease process. Okay? So now this stage, and if you there's also compared with the stage 1, when the black layer, the endothelium is normal. In this one, the endothelial proliferation has occluded the capillary lumen as well. So in stage 3 and stage 4, mesangium has proliferated, mesangium has expanded, endothelium has proliferated, and the basal membrane has split into multiple layers. Okay? Again, I would repeat, the splitting of the basal membrane only happens if the disease process also involves the basal membrane as well. Inflammatory glomerulonephritis causes proliferation of the endothelium, proliferation of the mesangium, and may cause proliferation of the Bowman's capsule as well, but it does not cause splitting of the basal membrane. Unless the disease process, the underlying disease process, has separately involved the basal membrane as well, causes the collagen dispersion within the membrane become loose and weak, and now the proliferating mesangial cells and the mesangial cells, they can actually physically enter into the basal membrane and split the membrane into two layers or multiple layers. This is called as tram-track appearance, and the disease is called as membranoproliferative. The word membrano in this mean the membrane is involved separately. Okay, and proliferative means the inflammatory process is causing proliferation of endothelium and mesangium. Right. So stage 3 and stage 4, they are basically mesangial proliferation, endothelial proliferation, and also involvement of the basal membrane as a separate process. Okay, and the stage 3 and stage 4, because they are the same, the only difference is stage 3 is focal and segmental. Only focal means less than 50% of the glomeruli are involved, and segmental means the glomeruli which are involved, only a part of the each glomerulus is involved, not the full extent of each glomerulus. Okay. Stage 4 is diffuse, which means more than 50% of the glomeruli in the biopsy specimen, they are involved. For example, when we take the biopsy, there need to be a minimum number of the glomeruli in each biopsy specimen for the biopsy to be adequate in sampling. And for example, there are 10 glomeruli. Out of those 10, if more than 50%, which means 6 or 7 glomeruli are involved, that is stage 4. Okay. Stage 3, less than 50% of the glomeruli are involved. So because stage 4 and stage 3, they involve the mesangial proliferation. They cause endothelial proliferation as well. And they also cause splitting of the basal membrane and thickening of the basal membrane as well. So they cause the maximum capillary occlusion and maximum capillary damage. So they are the worst stage of the lupus nephritis. And unfortunately, stage 4 is the worst one because it's diffuse. It's more worse than the stage 3. And unfortunately, stage 4 is also the most common type of glomerulonephritis in lupus patients. Okay, stage 5 is just the basal membrane is involved. Look at this figure 3. Mesangium is normal in the figure 3. Bowman's capsule, the green layer is normal. Endothelium, which is black in this picture, inside the capillary is normal. Only the basal membrane has split, basal membrane has widened and has become leaky. So only basal membrane is involved. Rest endothelium and Bowman cells are normal. So only remember the rule of 3 layers versus 1 layer. Because in this stage 5 only basal membrane is involved, endothelium is okay, capillary structure is okay, and Bowman's capsule is okay. Capillary is not rupturing. So there's no glomerular hematuria. It just causes nephrotic syndrome. Okay. So going back to the stages, remember the stages of the SLE, lupus nephritis, they are not based on the severity. If you think that stage 5 should be the worst one, that's not the case. Stage 4 is the worst one, which is diffuse proliferation of the mesangium and endothelium and the basal membrane, figure 2. Okay. Whereas figure 3 is a stage 5. So basically, the classification, if you look at these figure 1, 2, and 3 now, basically the classification of the lupus nephritis is more based on the anatomical location of the disease rather than the severity of the disease or severity of the inflammation. So stage 1 and stage 2, they're mainly confined to the mesangium. Stage 2, stage 3 and stage 4 figure 2, they involve mesangium, plus they cause capillary endothelial proliferation, plus they involve the membrane as a separate process. Okay. Stage 5, mesangium is fine, capillary endothelium is normal, Bowman's capsule is normal. Only thing you find is membranous splitting of the basal membrane, thickening of the basal membrane because of the collagen dispersion, and proteinuria. So stage 5 just present as a nephrotic syndrome. It doesn't have any glomerular hematuria. Stage 3 and 4, because it causes proliferation and inflammation, so that causes nephritic syndrome. In addition, because it involves the basal membrane as well, which causes proteinuria, so it can cause nephrotic syndrome as well. So stage 3 and stage 4, basically a combination of nephritic plus nephrotic. It could be a variable combination. Patient may have a dominant nephrotic syndrome with some nephritic element, or patient may have a nephritic syndrome with some nephrotic element, or maybe full-fledged nephritic and full-fledged nephrotic syndrome as well. So stage 3 and stage 4 can be any combination of nephritic syndrome, which means glomerular hematuria, and nephrotic syndrome, which means glomerular proteinuria because basal membrane is also involved. Stage 5 is only nephrotic syndrome, no nephritic pattern, no glomerular hematuria because only the basal membrane is involved. Stage 1 and 2, either they're asymptomatic or there's a mild nephritic syndrome, inflammation, damage, and hematuria. Stage 6 is a diffuse glomerulosclerosis, is the end result of look at the figure 6, which is here. The whole of the glomerulus is basically fibrosed now. Okay, there's no capillaries, nothing else left. That's the stage 6 or advanced stage of the glomerulonephritis. Now, stage 3 and stage 4, when they are severe enough, they, in 5 to 10% cases of glomerular lupus nephritis, they can progress to the rapidly progressive glomerulonephritis, or they can make crescent as well. Look at compare the figure 2 and figure 4. Figure 2, mesangium has proliferated, black capillary endothelium has proliferated, and membrane has thickened and leaky. This is stage 3 and stage 4. And here, because it's the worst form of glomerulonephritis, stage 3 and stage 4. So if they're severe enough, they can advance into the crescent formation, and they can make crescents in the Bowman space called rapidly progressive glomerulonephritis. Okay, right now, but this thing happens only in like 5 to 10% cases of the severe stage 4 lupus nephritis. Okay, now compare this crescent formation with the crescent formations of ANCA vasculitis or anti-GBM vasculitis. I want to highlight this difference here. Proliferative glomerulonephritis, such as lupus nephritis, when they cause crescent formation, there is, prior to the crescent formation, there's mesangial proliferation, this blue one, there's capillary endothelial proliferation, the black in this picture, which is including the capillary lumen, and the membrane is also thickened and widened. So capillaries are mainly occluded. In this whole background, you find the crescent. Okay. Whereas in figure 5, there is crescent formation, but the mesangium is normal. There's no mesangial proliferation. Capillary endothelium is normal. There's no capillary endothelial proliferation, and the basal membrane is normal, but you can see a rupture in the capillary. So these antibodies, oncovasculitis antibodies or anti-GBM antibodies, what they cause is they rupture the glomerular capillary, and that leads to the blood into the Bowman space, and that fibrinogen in the blood causes crescent formation. So there is a crescent formation, but mesangium is normal, capillary endothelium is normal, and capillary basal membrane hasn't expanded. There's only rupture of the capillaries and crescent formation. So compare these two crescents. Okay. Crescent formation because of a severe proliferative glomerulonephritis will have background of mesangial proliferation, capillary endothelial proliferation, and may have a membrane thickening as well. And then there is a crescent formation. Crescent formation because of oncovasculitis or because of anti-GBM syndrome, which is good passage syndrome, will have no mesangial proliferation, no capillary endothelial proliferation, no thickening of the membrane, just a rupture of the capillaries and crescent formation. So absence of mesangial and endothelial proliferation and any widening of the basal membrane in the setting of crescent formation means you are dealing with oncovasculitis or anti-GBM. Whereas presence of mesangial proliferation, endothelial proliferation, and or the membrane involvement with crescent formation mean these crescents are due to any underlying proliferative glomerulonephritis. So this difference is important because when we talk about how to differentiate lupus from the oncovasculitis, one of the differential point in the renal biopsy will be: is there any mesangial proliferation? Is there any capillary endothelial proliferation? Is there any membrane splitting? Or in the background of the crescent formation, or there are just crescent formation due to the capillary rupture, and there's no mesangial proliferation and there's no capillary endothelial proliferation. In addition, the oncovasculitis or anti-GBM, they are not the immune complex diseases, so there will be no immune complex deposition, and often there's no complement system deposition as well. This is another differentiating point between lupus nephritis from the oncovasculitis nephritis. And another point which is important, one is absence of mesangial and capillary proliferation. This one. Second is absence of immune complex deposition and complement deposition. These 2 points, they differentiate lupus, any proliferative glomerulonephritis making crescents from oncovasculitis or anti-GBM making crescents, okay, and causing RPGN. Another important point is presence of vasculitis within the kidney, outside the glomerulus, but within the kidney tissue, okay. Arterioles, branches of the renal artery, arterioles, and the peritubular capillaries. If it's an oncovasculitis, there may be a extraglomerular but intrarenal vasculitis. Okay. Extraglomerulus means outside the glomerulus, there's also inflammation of the capillaries or the arterioles or the branches of the renal artery within the kidney, outside the glomerulus but within the kidney tissue, and those vessels are inflamed. So that is another clue that you are dealing with oncovasculitis. Anti-GBM doesn't involve vasculitis. In addition, anti-GBM may have a pulmonary alveolar involvement as well. And similarly, oncovasculitis can have lung involvement and other tissue involvement as well. So extra-renal involvement, number one. Number two, extraglomerular but intrarenal vasculitis. Number 2, absence of the immune complexes and the complement. Number 3, and absence of mesangial proliferation and capillary endothelial proliferation in the presence of the crescent formation indicates you are dealing with oncovasculitis or anti-GBM. And remember, crescent formation without proliferation uh, is is seen in 80 to 90% cases of oncovasculitis causing glomerulonephritis. We'll talk more about oncovasculitis affecting the kidneys as a separate topic as well, but it's very important differential diagnosis of severe glomerulonephritis in lupus cases as well, especially stage 4 lupus nephritis causing RPGN. Uh, Oncovasculitis and anti-GBM becomes as a differential, so we should be very clear how to differentiate these two. Okay. Now these are the glomerulonephritic changes in SLE and their pattern. Now let's still in the glomerulus. Okay. So in addition to these stages of the glomerulonephritis, there are other diseases in SLE cases which involve the glomerulus, but they are not included in the classification or in these stages, stage 1, 2, 3, 4, 5, and 6. Okay, so they're separate from those stages. But these are important because patient will have lupus, they will have glomerular findings like glomerular hematuria or glomerular proteinuria. We will think that the patient has lupus nephritis, lupus glomerulonephritis, and the patient will be started on immunosuppressant. But these patients will not respond to the immunosuppressants when it's not glomerulonephritis and there is something else affecting the glomerular capillaries due to the lupus. Okay, so let's see what are those diseases. If you look at this picture, this is a list of the more common ones. One is SLE-induced thrombotic thrombocytopenic purpura, SLE-induced TTP. Second is SLE-induced hemolytic uremic syndrome, HUS. Third is SLE-induced microangiopathic hemolytic anemia, MAHA. And fourth is SLE-associated antiphospholipid syndrome, making blood clots in the glomerular capillaries. All these 4 diseases, they make clots, they involve the glomerular capillaries. So the patient will have glomerular failure, patient will have glomerular findings such as glomerular hematuria and or proteinuria in the setting of renal failure, and patient is known to have SLE. So the first possibility which comes to our mind is that this is the lupus glomerulonephritis. Okay, the biopsy can differentiate these, but there will be other clues as well. Remember, let me simplify these things rather than going into the exact molecular detail, but to give you a clear concept what they mean. Okay, if you include DAC as well, DAC can also give you the similar picture. Now, important differentiating points there, but before I go into those details, let me give you a very simplified version, which is not actually a true version, but that is what you need to remember to understand these things. Okay, so TTP and HUS, they are basically platelet plugs. They are plugs of the platelets blocking the glomerular capillaries. The other body capillaries can also be involved, but glomerular capillaries, because we're talking about the glomerular findings, so we will focus on the glomerular findings rather than the systemic finding, but the patient may have other organ involvement as well in TTP and HUS. But the basic defect is TTP and HUS, they are platelet plugs which block the small capillaries in the glomerulus and in other body capillaries as well. Okay, so when you block the capillaries, the consequence is same. Some of the capillaries will rupture, some of the capillary will cause ischemia. So because of the ischemia, the patient goes into acute renal failure, and because of the capillary damage, patient will have glomerular hematuria. So that will be confusing with the glomerulonephritis. So this is how clinically they mimic like glomerulonephritis, and if the patient has extra renal manifestation as well, then they can be confused with the small vessel vasculitis as well. So remember, TTP and HUS, they are platelet plugs, whereas DIC are microclots, which include platelets plus clotting factor. Okay, so DIC will have thrombocytopenia plus abnormal clotting tests, so like abnormal PT and APTT, and high fibrin degradation products, in addition to acute renal failure and glomerular findings, glomerular hematuria and acute renal failure with thrombocytopenia. Okay, so remember, glomerular hematuria, renal failure, and thrombocytopenia is common in DAC, TTP, and HUS. But DAC also causes clotting factor deficiency as well, which will cause IPT and APTT, abnormal PT APTT, in addition to thrombocytopenia and acute renal failure and glomerular hematuria. TTP and HUS, they cause thrombocytopenia because they're using platelets. So they're making platelet plugs and blocking the glomerular capillaries. So they cause glomerular hematuria, they cause acute renal failure, they cause thrombocytopenia. But unlike DIC, they don't use clotting factors, so the PT and APTT will be normal. So this is the main differentiating feature between TTP and HUS on the clinical ground. What are the clotting tests? If the clotting tests are normal, this is more likely TTP and HUS. If the clotting tests are abnormal, this is more likely DIC. Okay, and then TTP and HUS are basically because of the toxins or because of the autoimmune factors or because of the antibodies or anything which can damage the capillary endothelium, can cause platelet plug formation, or anything which can cause activation of the platelets that can also make platelet. So platelet plugs in TTP or HUS they are made because of two mechanisms. Either there's a capillary endothelium damage because of the toxins, because of the antibodies, because of the antigens, or there's a platelet activation such as von Willebrand factor related platelet activation, which happen due to ADAMTS deficiency. Okay, I'm not going to the detail of TTP and HUS, but remember how they can confuse with SLE causing glomerulonephritis, because they can cause hematuria, glomerular hematuria, they can cause renal failure, and they affect the glomerular capillaries. But they don't respond to the immunosuppressants. This is the main clinical concern. So we treat the patient as a lupus glomerulonephritis, but they don't respond to cyclophosphamide or prednisolone. So we do the biopsy and it might be TTP or HUS. So these things may be overlooked. So it's very prudent in patients who are having lupus glomerulonephritis to do the relevant blood test for platelet count and clotting factors as well, to make sure we're not dealing with DAC, TTP, or HUS. Of course, biopsy will pick them, but even without biopsy, we can get some clues clinically that patient has severe thrombocytopenia, patient has abnormal platelet deficiency, and patient has clotting abnormality as well. Microangiopathic hemolytic anemia, in simple words, what I can say is DAC is a microclots in the capillaries made up of platelets and clotting factor. TTP and HUS are microplugs made up of only platelets. MAHA, microangiopathic hemolytic anemia, basically you can remember in simplest words that they are plugs of the red blood cells. Just like TTP and HUS, they are plugs of the platelets. MAHA can be taken as plugs of the red blood. So basically the patient has microangiopathies causing hemolytic anemia, which causes plug formation of the red blood cells, which block the capillaries, and there's intravascular hemolysis. I'm not going into the detail, but their patient has intravascular hemolysis and patient has capillary blockage causing glomerular findings. Antiphospholipid syndrome can be isolated, or in most of the time, more than 50% cases, it's part of the SLE. So SLE patients are very high risk to have antiphospholipid syndrome. So it can also make blood clots within the glomerular capillaries. In addition to the major arteries and the veins as well, it can also make it can just involve the capillaries. It may or may not have blood clots in the major arteries or the veins. The more common finding of antiphospholipid syndrome is the blood clots in the major arteries and veins. But less commonly, antiphospholipid syndrome can just present with blood clots in the capillaries. So that will be very classically confused with glomerulonephritis. Okay. The other diseases which SLE can involve can cause in the kidneys is tubular diseases, like such as tubulointerstitial nephritis. So SLE can make antibodies or can cause immune complex deposition in the basal membrane of the tubules as well. And they can cause, just like glomerulonephritis, that immune complexes will activate the complement system and bring the inflammation there. And they will cause acute tubulitis or chronic tubulitis, inflammation of the tubule, damage to the tubule, and inflammation in the interstitium as well. So they can cause acute tubular interstitial nephritis or chronic tubular interstitial nephritis. Similarly, SLE can involve just a small part of a tubule or just one of the channel in the tubule. For example, SLE can make antibodies against the sodium-potassium 2-chloride channel in the loop of Henle, in the ascending limb of loop of Henle, and can cause acquired Bartter syndrome. Similarly, SLE can make antibodies against the carbonic anhydrase inhibitor, carbonic anhydrase, and can cause type 2 renal tubular acidosis. SLE can make antibodies against the proximal tubule and can cause Fanconi syndrome, acquired Fanconi syndrome. SLE can make antibodies against sodium potassium chloride channel in the distal tubule and can cause acquired Gitelman syndrome. SLE can make activating antibodies against the aldosterone receptor and can cause acquired Liddle syndrome. So SLE can cause all those tubular dysfunction. It can cause either diffuse tubular damage by causing tubular interstitial nephritis. It can cause focal tubular damage. It can cause isolated attack on the single or more than one ion channels and can cause various syndromes. As I mentioned, Bartter syndrome, Gitelman syndrome, Liddle syndrome, or Fanconi syndrome, and few other syndromes as well. Okay. So the SLE is not only glomerulonephritis. Most of the time it involves the glomerulus, but these tubular disorders can be there along with the glomerulonephritis, or it can be in isolation. Okay. Third important thing which SLE can cause in the kidney is SLE vasculitis. SLE induced small vessel vasculitis. Okay. Just like ONCA or anti-GBM vasculitis, SLE can also cause a small vessel vasculitis. This is secondary small vessel vasculitis, and that can cause inflammation of the glomeruli, causing picture similar to the glomerulonephritis. But also the patient will have intrarenal but extraglomerular within the kidney but outside the glomerular, involvement of the tubules and involvement of the peritubular capillaries and involvement of the arterioles as well, or venules. So vasculatic changes within the kidney but outside the glomerulus in a patient with SLE, and those who are ONCA negative and those who are negative for other vasculitis can be due to lupus and lupus related secondary small vessel vasculitis. RPGN, rapidly progressive glomerulonephritis, we have already spoken. When it causes severe proliferative GN, can cause this figure 4 can cause crescent formation, and that happens usually in 5-10% of the cases. Okay, so these are the various diseases of the SLE which can cause. To summarize, basically what we commonly read is stages of the glomerulonephritis: stage 1, 2, 3, 4, 5, 6, which we already talked. Then diseases which are not glomerulonephritis, but they can confuse with glomerulonephritis, and they can happen in patient with lupus, like DIC, like TTP, like HUS, like microangiopathic hemolytic anemia, and like antiphospholipid lipid syndrome related blood clots in the glomerular capillary. Then non-glomerular diseases such as tubular interstitial nephritis, tubular dysfunction, and various tubular syndromes, and renal vasculitis, and rapidly progressive glomerulonephritis. Okay, so just to summarize the various stages again, this picture, figure 1, is stage 1 and 2, only mesangium. The blue area is proliferated endothelium, which is black, and the basal membrane, which is red, and the Bowman's capsule, which is green. They are normal. Figure 2 is showing stage 3 and stage 4. You can see the mesangium is proliferating, the blue area. The black, and which is capillary endothelium, has proliferated and included the capillary lumen. And red, the basal membrane is sublate, it is widened, it has become leaky, but the Bowman capsule is fine. Figure 3, which is stage 5, just the membrane is involved, mesangium is normal, endothelium is normal, Bowman capsule is normal. Figure 4 is a complication of severe stage 4 or stage 3, which causes crescent formation as well, and ends up in rapidly progressive glomerulonephritis. Figure 5 is just for comparison with oncovasculitis and anti-GBM. When there are crescents, but with normal mesenterium, normal capillary endothelium, and normal basal membrane, except the only finding is ruptured capillaries with woman's capsule filled up with crescents. Figure 6 is a diffuse glomerulosclerosis, which end stage disease. Okay. Now, coming to the investigations of lupus nephritis, basically, because as you must be aware now that it's not only a glomerulonephritis. There are so many other diseases which SLE can cause in the glomerulus or outside the glomerulus, but within the kidney. Okay, such as vasculitis, such as TTP, such as HUS, such as microangiopathic hemolytic anemia, such as antiphospholipid syndrome related blood clots, such as tubular diseases and tubular syndromes. So there's so many. So it's always imperative in patient with the SLE who presents with the lupus to do a renal biopsy. Okay, the renal biopsy should be done in every patient of SLE when they are diagnosed with the lupus and they have renal involvement. Renal involvement is usually present in 60 to 80% cases of the lupus, and is second and third most common organ involvement in patient with the lupus. Okay. Now, the renal biopsy is very important. Number one, for the initial diagnosis. Now, if the patient has SLE and the initial diagnosis shows stage 4 lupus nephritis, okay, so that we know the stage 4 is the first form of the lupus nephritis or is the severest form of lupus nephritis, okay, and this has two implications. Number one, of course, that indicates that we need to hit hard and give a strong immunosuppressant. Number two, if the patient has a flares in the future, we know that the patient already has the worst form of the lupus nephritis, so we will treat it again as a stage 4 lupus nephritis, okay? But think, for example, the patient initially presented with the lupus nephritis and it was stage 2 or stage 3, and we treated it. Either the patient didn't respond or the patient had a relapse and or patient got worsened. Now there's a possibility that the disease might have progressed to stage 4. So now we need a biopsy again. So if the initial biopsy showed that it was stage 2, stage 3 or stage 1 or stage 5, but not stage 4, and there's a subsequent lack of response to the treatment, or there's a subsequent worsening of the disease despite the treatment, the biopsy need to be repeated just to emphasize that the disease hasn't progressed and become as a stage 4, which is diffuse membranoproliferative glomerulonephritis involving the mesenterium, endothelium, and the basal membrane. Okay? Second, the third indication for the renal biopsy in these patients is lack of response to the treatment. When the patient doesn't respond, we think that patient has a lupus nephritis with biopsy or without biopsy. The patient started on the immunosuppressant therapy. We'll come to that in a few minutes. But the patient doesn't respond. Okay? In those cases, we need to make sure it's not something else other than the glomerulonephritis. Okay, before we keep increasing the immunosuppressant, because these immunosuppressants have a lot of side effects as well. So we need to make sure that we are justifying the increase, stepping up of the immunosuppressive therapy. So we do a biopsy to make sure it's not a TTP or HUS or microangiopathic hemolytic anemia or antiphospholipid syndrome or tubular disorders, etc., which we are thinking that this is lupus glomerulonephritis, but actually it's not inflammatory process. So those diseases, they have their own treatment. For example, TTP may need anti-complement antibodies such as the eculizumab. Okay, and similarly, MAHA will have different treatment. Antiphospholipid syndrome will have a different treatment, which include anticoagulation and those stuff, right? So, and RPGN will have a different treatment. Similarly, oncovasculitis and anti-GBM needs plasma exchange, usually in the very early part of the disease. So it's very important to repeat the biopsy or to do the renal biopsy if it's not already done in patients who lack adequate response to the immunosuppressive therapy. Ideally speaking, every patient of the lupus should have a biopsy when the renal involvement is there in the first go. And if it's a stage 4, then after the repeat biopsy is not needed. But if there's lack of response at any stage, or there's a relapse, we need to do the biopsy. Another reason for doing a renal biopsy is if the patient, despite using adequate immunosuppressants and all the inflammatory markers, they have settled down. For example, complement have normalized in the blood, and there's no glomerular hematuria, but the patient's renal parameters are not improving. Patient GFR is not coming up, is not picking up, or the proteinuria is persisting, or the hematuria is persisting. The rest other systemic parameters have normalized. So in these cases, there's also another possibility of chronic damage, that the kidney has chronic damage. That's why there's no improvement. So basically, people who do not respond to the immunosuppressants, uh, okay, there are two main possibilities. Either this is not an inflammatory process, such as it could be a TTP or HUS or MAHA or antiphospholipid syndrome, or there's a chronic damage. No matter how strong immunosuppression we are going to increase, it's not going to work. Because if there's a fibrosis, immunosuppression is not going to reverse it. So biopsy is also needed in those cases to exclude non-glomerulonephritic problems, number one. Number two, to exclude chronic damage such as fibrosis which has already happened. Number three, to establish the diagnosis and to establish the stage of the disease. And number four, if there's a lack of response, to say what is there any other additional pathology or some alternate diagnosis going on. The other renal specific test which we do for the renal patient and in SLE patient with the renal disease is anti-double stranded DNA antibodies. They are very specific for the internal organ involvement, especially for the brain and for the kidneys. Okay, they are called as poor man's renal biopsy. So positive anti-double-stranded DNA antibodies, they strongly indicate, especially if they're positive in a high titer with a specific test, this strongly indicate that there's more likely a renal involvement and more or the brain involvement. Okay, but they're not very sensitive. The sensitivity is very poor. So normal anti-double-stranded DNA antibodies doesn't exclude renal disease or internal organ disease. But if the anti-double-stranded DNA are positive, they are very strong indicator of the renal disease, even if it's clinically not symptomatic. Okay, that they are the clue that we should work up for kidney disease. Sometimes if the patient is not filling for the biopsy and the patient has, patient has a clinical involvement of the glomerular such as proteinuria and hematuria. In the setting of the patient is known to have lupus and anti-double-stranded DNA are positive. In those cases, if the patient is not filling for the biopsy, anti-double-stranded DNA antibodies are a very strong clue that we are dealing with lupus glomerulonephritis and we should treat it for the lupus glomerulonephritis. With the disease remission, these antibodies, anti-double-stranded DNA antibodies, they become negative. Sorry. Okay. So rising titer of anti-double-stranded DNA antibodies also is a good clue for relapsing disease most of the time. You're right. Now, another important thing which every SLE patient should have when their renal involvement is a screening for the antiphospholipid syndrome. As we discussed before, antiphospholipid syndrome, either alone or as part of the antibody, can involve the glomeruli, can make thrombi within the glomerular capillary, and can present in addition to the glomerulonephritis or as a sole pathology. Okay, so when we will use the immunosuppression, the glomerulonephritic component may improve, but the thrombotic component may not improve, will not improve. So it's important to exclude and to do the blood test for antiphospholipid antibodies as well in every patient with SLE who has a renal involvement. Okay. Now, if there's a clinical suspicion of TTP or HUS or microangiopathic hemolytic anemias, certainly those tests also need to be done. Okay. Proteinuria should be quantified, and because that will help us monitoring the management. Okay, but For example, if the initial protein urea was more than 500 milligram per day, and it now with the treatment it falls below 500 or 300, that means their patient has improved. So initial quantification of the protein urea is very important. Sometimes the hematuria can persist with if the other parameters have normalized, renal functions have normalized, complements have normalized, and the protein urea have normalized, only hematuria is persisting. It could be because of very subtle disease, or it could be because of the cyclophosphamide which is used, or some other reason for the hematuria to persist. So just persistent microscopic hematuria in the presence of all the other parameters which have normalized doesn't mean that we need to increase or boost the immunosuppression. That okay, sometimes the glomerular hematuria can persist at a microscope level because of many other reasons other than the active disease. Right now, coming to the treatment, I haven't gone into the detail of the screening tests and those monitoring tests for the lupus nephritis because of the short of the time, but we'll discuss them in detail. Just to give some idea about how do we treat them. Basically, the treatment of the lupus nephritis depends on the severity of the disease and the underlying disease. For example, as I said, if it's not glomerulonephritis, it's an antiphospholipid syndrome related microclots in the glomerular capillaries, patient will need anticoagulation and patient will need other treatments for antiphospholipid syndrome rather than cyclophosphamide or immunosuppressant. Okay, if the patient has oncovasculitis or anti-GBM, the treatment will be plasma exchange and immunosuppressant. So treatment really depends upon what is the underlying disease process affecting the kidney. If it's an inflammation causing glomerulonephritis or intrarenal vasculitis, then certainly we will use the strong immunosuppressant. Okay, and usually if you look at this diagram is a diagram for the treatment. So remember, let's take the MP stand for methylprednisolone, CYC stand for cyclophosphamide, RTX stand for rituximab. Basically, for the severe disease, for severe stage 3 and stage 4 disease, or disease which is RPGN, these diseases, they usually need a strong immunosuppressant, and they are given the strongest immunosuppressant such as methylprednisolone and cyclophosphamide. Okay. If the patient cannot have cyclophosphamide, then of course, for example, if the patient is young and the fertility is a concern, right? Or the patient is very frail for cyclophosphamide, patient is old age, frail, can't tolerate cyclophosphamide, or the patient has previously given 1 or 2 sessions for cyclophosphamide, one or two induction therapies of cyclophosphamide, and patients already achieved the maximum dose of cyclophosphamide, which is usually the 36 gram in total. So in those cases, when we want to preserve the fertility when the patient is young, reproductive age, or the cyclophosphamide toxicity is a major concern, or the patient is very old and frail, or the disease is not imminently threatening the glomerular survival and patient is not heading toward the dialysis. In those cases, when the disease is still not very extremely severe, we can try rituximab instead of cyclophosphamide, methylprednisolone with rituximab. If the patient uses cyclophosphamide for induction and they fail, then we can use rituximab instead of cyclophosphamide. Vice versa, if it was rituximab used in the first go and that has failed, we can switch to the cyclophosphamide. Or another option is we can combine cyclophosphamide and rituximab together. But if all these tricks fail, like for example, replacing cyclophosphamide with rituximab, replacing rituximab with cyclophosphamide, or combining cyclophosphamide and rituximab, if all these tricks fail and disease is worsening, then the next step is to step up, to add PLEX, plasma exchange. Okay, the way plasma exchange works is it filters the toxins and antibodies and immune complexes from the blood and has immediate rapid action. But the problem is it removes all the clotting factors and plasma proteins from the blood. When it removes plasma protein, it removes antibodies as well. and causes severe risk of infection. It removes albumin as well, causes severe hypoalbuminemia. It removes clotting factor as well, and causes severe bleeding risk as well. So usually the patients are given replacement with albumin and or clotting factor or whole of the plasma, and is a limited therapy only for the acute severe cases such as RPGN or such as those who are not responding to methylpred, cyclophosphamide, and or rituximab. If the patient start responding to the induction therapy with methylpred, cyclophosphamide, and or rituximab, once the disease is under control, proteinuria has resolved, it has come down to less than 500 milligram per day, hematuria is settling down, renal functions are improving, then we can step down to the maintenance therapy. And the step down therapy, the option is MMF, which is actually mycophenolate. Mycophenolate mofetil is not as strong as cyclophosphamide or rituximab, but it's quite strong. It's stronger than azathioprine. In cases with whoever like a not a very severe disease which needs cyclophosphamide or rituximab or methylprednisolone, for example, stage 2 disease or moderate stage 3 or moderate stage 4 disease, in those cases, we can start therapy from direct from mycophenolate rather than subjecting them to the more toxic drugs such as cyclophosphamide and rituximab. So mycophenolate can be initial option for mild to moderate glomerulonephritis, or okay, but it can also be an option for the maintenance therapy in severe cases after the induction has been achieved with a my methylpred and cyclophosphamide or methylpred or rituximab. Okay, if the disease is very well controlled and the risk of relapse is low, then we can also use maintenance by the azathioprine. Mycophenolate is more stronger than azathioprine for the maintenance purpose, but is also more toxic. Okay, so using mycophenolate is a choice for patients who have a difficult induction or who have a higher chances of relapse uh, after the induction therapy. So we use mycophenolate or rituximab as a maintenance therapy. Patients who have an easy induction or who have a less risk of relapse, they are usually managed by azathioprine as a maintenance therapy. Another advantage of azathioprine is safe in pregnancy, whereas mycophenolate, rituximab, and cyclophosphamide, they are not safe in pregnancy. 2 milligram per kg per day is safer dose of azathioprine in pregnancy. Patient, in some cases, if there's a autoimmune disease such as lupus, glomerulonephritis, and there's an infection as well. Now, if we use immunosuppressant, it will increase the risk of infection. So, intravenous immunoglobulin is a good choice. Okay. Similarly, intravenous immunoglobulins are also safe in pregnancy. So, IVIG therapy can be added as an additional option for pregnant patients, for patients who have concurrent infection, or patients who are not responding to the standard therapy. So I think I'll stop here and I'll be happy to take the question. You can stop recording.